Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Hello, and welcome to another episode of the INS Infusion Room. We have Barb Nickel in the house today. Welcome, Barb.
Thank you.
And with today's episode, this is part of our very special series where we're celebrating IV Nurses Day through a week-long celebration of free educational events directly for you. Be sure to tune in every day for an educational event, whether that be a podcast or webinar. They're all free and they're coming to you this week in celebration for the work that you do. So, Barb, we are talking directly about concurrent flow and shared volume today. Barb, introduce yourself to those who may not know who you are.
Well, I'm a clinical nurse specialist. I work in a very large health system. I worked in critical care for many, many, many years before I went back and got my advanced practice degree, and have done just massive work in quality improvement because of the value of the job that I have, but also done a great deal of volunteer work through multiple nursing organizations, obviously with INS on the National Council on Education for many years, and then as a co-author and then chair of the 9th edition of the Infusion Therapy Standards of Practice, and now again chair of the 10th edition. And so, coming to you with a very thorough knowledge of the research in this area.
Thank you, Barb. And I want to make mention that today's episode is sponsored by Fresenius Kabi. And we have a special message from the sponsor. Fresenius Kabi is a global healthcare company that specializes in life-saving medicines and technologies for infusion, including IV pumps, IV solutions, irrigation solutions, and clinical nutrition. Our products and services are used to help care for critically and chronically ill patients. In the U.S., we are a leading supplier of generic, sterile injectable drugs. So within that, let's go ahead and jump in. To get us started, can you talk about what shared volume is and define concurrent flow?
Yeah, this is an incredibly important topic that I don't believe nurses have as good of a grasp on as we need. So again, I'm very glad that this is the topic of a podcast. So shared volume, and it may also be in the literature referred to as dead volume, which I think probably shared volume is the better term. It refers to the volume from the bag of infusates that are up here, the actual medication in the bag, all the way down to the connection to the patient. So it's really everything that's in your administration sets that has not yet reached the patient. And it's shared volume because when we're giving concurrent delivery and maybe connecting several into one line of a vascular access device, there is a certain element of shared delivery or concurrent flow that happens within that line. And we have this clinical conundrum, really, because the standard is to put in the very smallest possible vascular access device with the least number of lumens in any patient, because that reduces many risks, especially thrombotic risk, but others as well, infection as well. And yet, how do we, on critically ill patients, deliver multiple infusions into a very small line? And so that creates then the possibility of concurrent flow where I'm daisy chaining, so to speak, several different infusions into one line of a vascular access device. And that's what we want to talk about, is the risks of shared volume and concurrent flow.
Yeah, so expanding on the significance, and you mentioned risk. What are those risks associated with concurrent flow?
There are many, and this really hits the spotlight. I think it has been known and studied. In fact, in the 2024 standards, we included this because the references were just so profound. in the med administration standard, and we created a table that really outlines the risks and the optimal practices in this area. But COVID really highlighted the risk here because again we were inundated with critical patients, and again coagulation was an issue, and so we were trying to limit number of lumens, moving pumps outside of the room, which created then just a huge risk for concurrent delivery. And so that, I think, really bubbled it up to the top. The risk is that, number one, there may be incompatibilities. Hopefully, nurses are checking on those. And so, as we talk concurrent delivery, we are assuming that compatibility has been validated. You obviously don't want to daisy chain an incompatible drug. And so that is a very important first skill. Then again, as we're adding subsequent infusions, potentially downstream, all infusing into 1 lumen, and then those are at different rates, potentially driven by different types of pumps. We are changing the dynamic all the way through and the flow rate, and in so doing, then the essential accuracy of the delivery. And so, unfortunately, during COVID, on those patients with multiple pumps, possibly, all connected together into various lines, we were not sure of the accurate delivery to these patients. And the lower the rate and the higher the criticality of the medication, the need to deliver it exactly accurately, like heparin, insulin, vasopressors, then the risk just escalates. So that paints the global picture of why this is such an important topic.
Agreed. And you mentioned that it is part of the standards. Can you talk a little bit about how it made its way into the standards?
So again, and that was a standard that there were, I believe, 3 authors that worked on, and so we were looking at it from different perspectives. And what I saw as the chair were topics within the flow control standard, meaning our devices that we're delivering, the administration set standard that talks about the tubings, and then medication delivery. And what I saw as we were working on it and developing the standards for the 9th edition was the overlap between those 3 topics. And so we felt that it would be important to pull that together rather than say the same thing multiple times throughout the standards. We pulled it all into a table that we felt would really help educators and clinicians to see what are the risks and what are the optimal practices. As we're working now on the 10th edition and nearly done with the initial drafts, again, this area of research has really escalated and we have expanded that table. So you'll see more content in this area coming out for the 10th edition.
How did the committee come to a consensus on this topic?
Just basically going through our strategy. We do a search strategy within the specific standards. And so what we do then as we're working on the next draft of the standards is to look at what is the most current research. We generally look from this point back 5 years. And then we really look to say what is new, what really is occurring in the references that brings a higher level, a new knowledge to the standards. And this is an area that really has advanced our knowledge of dose accuracy to our patients. And so what we do then is go through all of the references that have been pulled in by a search strategy and say what ones are high level, what ones really are impacting global practice, and we come to consensus with that. And then what does that evidence tell us on how to expand or edit the current standard? And again, that's the content that we've discussed so far. It was clear and compelling that this needed to have more room in the standard to inform our clinicians.
If we could hone in on the patient that has one PIV site with multiple medications ordered, what's best practice for medication delivery in this patient's plan of care?
That basically all of the infusions need to be peripherally compatible and obviously compatible with each other. In general, it's not wise to deliver multiple medications into one peripheral IV. And so looking at the regimen of medications that are needed to be infused and the urgency of that delivery really would probably escalate to at least a second peripheral line. And again, if it's real critical and we have difficult IV access, meaning I don't know that I'm going to be able to get a second peripheral, we may need to consider a central venous access if the patient is going to need therapy for a long period of time. The more we dump into a low flow, low hemodilution state, especially drugs that are very or maybe irritating to the endothelial lining, the more we escalate failure of those peripheral IVs. And so, yeah, running multiple drugs into one peripheral can be very, very dangerous. And again, I believe that's an area that nursing doesn't necessarily understand as well as we need to. So I think this is an area that we need to increase our knowledge of. Low pH, high osmolarity drugs, very damaging to the endothelial lining. And so we want to optimize the health of that peripheral vessel. And so again, trying to optimize or trying to put several things into a very small space with low blood flow will only cause that to fail quicker. And that's a harm to our patient. We need to think vessel health and preservation.
Agreed. Agreed 100% with that. So implementation is always a tricky aspect. And really, knowing the evidence is one key component, but then also knowing how to implement or implementing at the bedside is what makes the change truly occur. Looking at the key principles of shared volume, what is your recommendations for best way to implement this practice?
Well, first of all, would be a look at everything that's required for this patient and really think, how much access do I need for them? What do I have enough vascular access to really deliver this care with the urgency that they need? Is one or two peripheral IVs enough if they are peripherally compatible? But if I'm giving continuous vesicants, peripherally or peripheral vascular access device isn't necessarily the right way unless it's for a very short duration. And so first of all, vascular access selection is critical. As far as pump function, what is the best pump to deliver what I need to deliver accurately? If it's very small volume, possibly a syringe pump if that's available in your facility. Otherwise, check with your biomed department to see what is the infusion range. Can I do 2 mLs an hour? Is that safe on this particular pump? Avoiding adding multiple lines, daisy chaining, I use that so that they're all connected together, but they're staggered up, because when I change the rate of any of those lines, I'm altering the delivery of all of the drugs within that line. Even if they're all compatible, I still am not accurately delivering each one of those as the pump is dictating. A way to, or an option for that is, say, a multi-way extension set where you have 2, 3, 4, even up to 6 different extension sets all connected at a hub, and you can connect that hub on the lumen. And then you've got 3 actual ways. You've extended your lumen out 3, 4, 5, whatever times. They all have to be compatible, but you've eliminated the shared volume. And you can deliver all of those drugs right into that hub without all of that concurrent flow. Drugs actually infuse in a laminar flow just like our blood flow in our vessels. And again, every time we connect something, we've altered that laminar flow, and so we've altered the delivery of the drug. We want to limit tubing length, because when we increase tubing length, we decrease dose accuracy. We also increase restriction within the line or increase pressure. We want to manage our alarms as quickly as possible. And I'll just highlight occlusion alarms in this setting mostly, because occlusion alarms can actually increase pressure throughout your whole system. And so if it's gone for a little bit of time, and they do because we're busy with other things, then you've increased pressure within your line. And then once you resolve it, the pump might actually then push, and now you have additional pressure, possibly causing an inadvertent bolus of whatever drug you have. So we need to rapidly address occlusion alarms and eliminate them as much as possible by keeping patency in our line and reducing restrictions like positioning or blood pressure cuffs. And again, keeping pumps at a consistent level as much close to the manufacturer recommendation as possible within that complex setting. We can't alter their levels and expect accurate delivery. So knowing what your manufacturer settings are for your pump is very, very important.
So for the clinician that's working within an organization that has policies that are maybe conflicting with best practice within this specific topic, what are your recommendations to that clinician?
That's a very good question. Again, if you have a copy of the standards of that table, access to the research, the best way to come at policy change is to find your key stakeholders, your critical key opinion leaders, who is doing that policy for your organization, and then bring them the evidence and say, I see this, but from what I see in the evidence, that's going to impact X, our dose delivery. It's going to increase risk to our patients by this. So that's how you would, and that's how I've done it. I do policy procedure all the time in my organization. It has to be evidence-based. What does the current evidence say? And again, the standards brings that to you up to the time of publication. But we also would be glad to answer your questions. INS has a question board, and many of those are then given to the standards people to address. And we can not only tell you what was in 2024, but what's now in the current evidence. And we can help you with that, and we can guide you if you've got questions in that area.
Absolutely. Before we wrap up today's episode, do you have any final thoughts or words of wisdom for our clinicians that are listening right now?
Final thoughts. There's so much. But this is an area that I believe we don't own as well as we should. I think we just do it because we have to. And we are, again, I worked critical care for many, many years. And as I look back on all those years, I know that I did practices that maybe were not optimal. Now we're showing you there's ways to optimize. What we have to do is to bring our practice up to that level as soon as possible. We need to advocate for our patients. We need to be able to see, even just pick one thing in your practice that you feel would make a difference to your patients. And if this is it, really own it and reach out. I'd be glad to help you if you're doing a practice improvement, a quality improvement. But if we can just chip away at these areas that are causing our care to maybe be less than optimal, then we will gradually get to a point where we are delivering the very best care.
Thank you so much. As always, it's a pleasure having you within this studio. I'm your host, Derek, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.